Hey everyone, welcome, and thank you so much for joining us tonight. We're really excited that you decided to spend some time with us. My name is Chris Bishop. I'm the clinic director for both Seattle Regenerative Medicine Center in Bellevue and Juvicor Health in Tacoma. Before we dive in, just a couple of quick housekeeping notes. You are muted as an attendee, so don't worry about background noise on your end. If you have questions, go ahead and drop them in the Q&A box at the bottom of your screen. You'll see a pop-up anytime throughout the webinar, and we'll be able to get to those at the end of Dr. Hostetter's talk. So now let me go ahead and introduce the person you're here to hear from. Dr. Lucy Hostetter is the founder and owner of Seattle Regenerative Medicine Center, which she built from the ground up 8 years ago after spending many years working in the hospital setting. Most recently, she expanded her vision by opening a second clinic, Juvicor Health, this past February. Dr. Hosseter is passionate about helping people find their absolute best self, and today she's going to share everything she knows about hormones. So, Dr. Hosseter, take it away.
All right, great. Thank you, Chris. Appreciate that. Welcome, everyone, to our first webinar. I say first webinar because my hope is that we will be doing more of these because it will be nearly impossible for me to cover all of the topics related to hormones in a 45-minute or hour-long webinar. So I'm considering this the first of a series of webinars, and I really appreciate you all joining and am happy to provide education tonight. Really, that's what this webinar is meant to do, is educate you, because there is so much misunderstood about hormones. There's so much mixed messaging. You have physicians who say don't do it. You have others who say it's safe. And it's a really confusing landscape right now for anyone, those in medicine and those who are patients. And so I'm hoping to start the conversation and clarify some things for you all. So with that, we'll get started. Um, Here's our agenda for tonight. So we're going to just start with the basics. What are hormones? How do they work? And then talk about sort of how did we get into this place that we're in right now where there is so much confusion and misunderstood about hormones, what led to that. I want to talk about bioidentical hormones because this is something near and dear to my heart, something I believe in very much. And then address the different types of treatment therapies. We'll focus a bit on hormone pellet therapy because that tends to be what I prefer most, but we'll talk more about that. And then what it looks like to actually do HRT and optimize your hormones. So with that, let's start with, like I said, the basics, understanding hormones. So what are hormones? Your body actually makes numerous different types of hormones. What they are molecules that are produced by glands in our bodies. Many different glands can produce hormones, these molecules that get secreted into the bloodstream and then are carried to different tissues where they act via specific receptors. So when we talk about classic HRT, our most commonly, or the most common glands that are producing those hormones are the ovaries in women and the testes in men, but we also have adrenal glands, thyroid gland, pituitary gland. These also produce hormones. So once in the bloodstream, they travel to the cell tissues, they act on cells via specific receptors, and it's in a lock and key type of fashion. What this means is that each hormone has a specific receptor that it binds to. So you can't get all the different hormones binding to the same receptors. Each hormone has its own and fits like a lock and key. And essentially, these are chemical messengers. So they have widespread effects throughout our body. They can affect our mood, our energy, our sleep, really our physical health, our bone strength, our muscle mass, heart health, immune function, so much more. So hormones are absolutely critical, a vital part of our homeostasis or balance. And any type of change in hormone levels can throw multiple systems in our bodies out of whack. And we'll talk a little bit about that and how you experience that. When we're talking about hormone replacement therapy, we have some primary hormones that we typically are addressing. We have the sex hormones, which are testosterone, the estrogen, and progesterone. And then we have our supporting hormones, which often can help support the sex hormones and have overlap with some of the things that sex hormones do. So the supporting hormones primarily are thyroid and vitamin D, which I have an asterisk there for vitamin D because while it's not technically a hormone, it does act similarly and is like a pro-hormone. So I include that as part of the supporting hormone mix. So let's break down what each of these hormones are. So for men and women both have estrogen, and there are three major types of estrogens that are present. Probably the primary active estrogen is estradiol. Estradiol is really important for reproductive health. It plays a important role in bone density and preventing bone from breaking down. It is essential for our brain function, cardiovascular health. It helps maintain the health of our skin and helps provide sex drive as well as affects our metabolism and our mood. Typically, women will have their highest estrogens up through, or highest estradiol up until they hit menopause, which varies when that hits each individual woman, but typically somewhere between the ages of 45 and 55, and then estradiol will decrease. The other estrogens that are also involved, we have estrone, which is typically it becomes the primary estrogen that's present after menopause, and it's made where estradiol is made from the ovaries, estrone is primarily made from the conversion of testosterone. Testosterone gets converted by a enzyme called aromatase that will cleave part of the testosterone and produce estrone. And it can also produce estradiol, but after menopause, that's the primary source of estrone. It's present in the fat cells, helps support fat regulation, and helps to maintain the uterine lining. The weakest of the excuse me, the estrogens would be estriol, which is primarily seen in pregnancy and has very little effect outside of that. So, as I said, estradiol is present in both men and women. Men typically get estrogen or estradiol from conversion of testosterone, like I talked about on the last slide. So, that aromatase enzyme can convert testosterone into estrogen in the peripheral tissue in men. And in men, it's really important for, again, bone density. It has an effect on libido and erectile function, as well as cardiovascular health and body composition. In women, it's produced in the ovaries, particularly in premenopausal women. It can have an effect when it is decreased. We see changes in vaginal health, so it's important for that. It's important for breast and uterine health, as well as the others already mentioned. Progesterone. Progesterone is, we think of it as the balancing hormone to estradiol. So in women, it's primarily produced by the ovaries and it runs in balance with estradiol. It is also produced in the adrenals and the placenta. In men, it's primarily coming from the adrenal glands and it is a precursor to testosterone. So testosterone is made from progesterone. Effects, it can help support sleep. It helps in women maintain the uterine lining. It can reduce water retention and inflammation. In men, it helps with prostate health. And in women, it's important for balancing those estrogen effects in the breast, as well as helps maintain the uterine lining for the uterus. Testosterone. So, testosterone is the most abundant sex hormone present in both men and women. And I'm going to say that again so that it really hits home because this is something that is not talked about or understood near enough. Testosterone is the most abundant hormone in women and men. There's not testosterone's the male hormone and estrogen's the female. we have, as women, have more testosterone present in our body than we do estrogen. And as I already talked about, men also have estrogen. So this idea that these are male and female hormones is not accurate. It's just that their roles are different for us. It is produced by the ovaries and testes as well as the adrenals, and there are the glands can also produce precursor molecules that in the peripheral tissue can be converted to testosterone. And it's critical in many systems, including affecting sex drive, our bone and muscle mass, and our heart health. It really gives a sense of self and well being. And when testosterone levels decrease for men and women, you can see widespread changes that I hear people say all the time, I just don't feel like myself anymore. Very often, that is because the testosterone levels have decreased below a threshold where they're now no longer having the effects that they were previously having for you. And those effects, it can affect cognitive function. So people will talk about having brain fog, word finding difficulties, difficulty with memory and focus. They'll have more anxiety, depression. They may feel like they're sweating a lot more, running hot, having night sweats, low sex drive. And that low sex drive is I want to have sex, but I don't want to have sex. And it's almost an imprisonment in that feeling. Absolute fatigue, exhaustion, low motivation to do things, increase in joint pain, thinning hair, and weight gain. These are classic symptoms. And for women, these are often the symptoms that present in perimenopause, which is the period before they actually stop having their menstrual cycles, when testosterone levels have dropped, but they're still making enough estrogen to produce the menstrual cycle every month. So to drive this point home, looking at this slide is to demonstrate how much more testosterone women can have than estrogen throughout their monthly cycle. So during the ovulation phase, when estradiol is at its highest, we still have typically around twice as much testosterone in us than we do estradiol. In our menstruation phase, when estradiol is low, that decrease can, or that increase in testosterone can be upwards of 15 to 25% or times higher. What is mind-boggling and frustrating as a woman and as a physician who treats both men and women is that there's absolutely no FDA approved testosterone replacement available for women. It has been completely disregarded as an important hormone for women. It is, if ever brought up, it's only brought up as a treatment for sex drive, a low libido. But obviously, as I talked about, there's multiple effects of testosterone in men and women, and it's vitally important that women have it. And it is absolutely a fault of our system at this point that there is no recognition of that from our FDA. Hopefully that will change, but as of now, that is the situation. There is FDA approved testosterone for men, however. So again, males and females have the same primary sex hormones, which differ. What differs is how much and then how they affect each of the body for men and women. So men will produce 10 to 20 times more testosterone than women. Similarly, women will produce 10 to 20 times more estradiol than men and as well progesterone. This is a really interesting graph to show, though, the difference between hormonal fluctuation in men and women. So, men with their testosterone being their primary hormone, they will have fluctuations in the levels, but men typically, those fluctuations occur on a daily basis, in that testosterone is highest in the morning, and in the evening and at night, it tends to bottom out. And this is pretty much how they cycle throughout the month is wake up in the morning with high testosterone, starts to diminish by the end of the day, rinse and repeat. For women, you can see there is over a 1 month period quite a different pattern in hormone fluctuation, where there are peaks and valleys, and depending on where they are in their cycle, they may have higher levels of estrogen than progesterone, and so on and so forth. So now talking about the supporting hormones. So thyroid's a really important hormone. It is a metabolic hormone. It is a gland present right here in our neck, and it produces two types of hormones. There's T4, which is thought of as the storage form of the hormone, and T3, which is the active form. T3 is actually produced from T4. So the thyroid will produce T4 and then it gets converted into T3 in the tissue. Really important for affecting metabolic rate, energy production, body temperature regulation, weight management, as well as brain and brain function and mood. When thyroid levels drop, when thyroid hormones levels drop, there are classic symptoms that we can see. People will feel more tired, they'll notice more weight gain, they'll get thinning hair, they'll have intolerance to cold, maybe cold fingers, cold feet, and a depressed mood. So low thyroid can actually have similar effects as what we talked about with testosterone and estrogen, and this is why I call it a supporting hormone. If we just address your sex hormones and we don't acknowledge that thyroid has a role, then you may not feel optimized as you're getting your hormone replacement because there is still a missing hormone there that may need optimization. So these hormones are interconnected, and thyroid hormone is something that needs to always be checked in anyone considering getting hormone replacement therapy. Vitamin D, as I said, that is a prohormone. It acts as a regulator of genes in our bodies, and it helps activate hormone receptors in all of our tissue, including the brain and the bone and immune systems. When someone has low vitamin D, which by the way, we're in Washington State, it is rare that I see someone without low vitamin D. And if I do, invariably it's because they're already taking a vitamin D supplement. Vitamin D is produced in our body. We create it in our body, but we need sunlight for it. And given how limited sunlight, direct sunlight is in Washington State, it is really quite prevalent to have a vitamin D deficiency. Low vitamin D can produce symptoms of fatigue, bone pain. It's really important for our immune system, so frequent illnesses and weakness, brain fog, that sort of thing. So it really can also impair the body's ability to produce hormones as well as utilize them properly. So it's very important in any hormone optimization program. So, with all that, our hormones decline with age. So, men and women have their highest levels when they're in their 20s, and then they start to decline. For women, we will see testosterone start to decline in our mid to later 20s. And for men, we will see that they will, by the time they reach the age of 35, they start decreasing their testosterone production by 3% per year after that. So many people, by the time they're in their 40s and 50s, will be experiencing symptoms of this drop in hormone levels. Every day, you have 3,500 women entering menopause, but the symptoms of that can start long before menopause, up to 15 years before. So that means that some women starting in their mid to later 30s may start developing symptoms of perimenopause. And 40% of men over the age of 45 have symptomatically low testosterone. So, what are the symptoms of hormone depletion? We've kind of touched on a little bit, but I'll go through them by system. So, it can affect your brain function and mood, causing brain fog, decreased concentration, mood changes, depression, irritability, has an effect on sleep where You either have a hard time falling asleep or difficulty staying asleep. I can't tell you how many times I've heard people say, I wake up at the same time every night. And it's like they have an internal alarm clock that goes off. That's an effect of the hormone depletion. Chronic fatigue, low energy, low motivation, weight gain, decreased muscle mass. Men will talk about men who have lifted weights for years will talk about how it's harder to see the gains in their weightlifting and it's harder to recover afterwards. And they're just not seeing the strength, and women as well, just not seeing that strength being maintained. Has effects on hair. Thinning hair definitely occurs, as well as dry, aging skin, nails that break easy or split or crack, and just that loss of a glow that we're all sort of seeking in our skin. It just starts to look dry and flaky and crepey. Sex drive, big one. This can start to decrease for women in their later 30s and certainly for men in their mid to later 40s. Women can see vaginal changes where they might have thinning of the vaginal wall, causing vaginal dryness and painful intercourse. Men may see erectile dysfunction, as well as just a loss of drive in general. And then specifically, a couple things for women is hot flashes. Classic hot flash starts right here in the core and spreads out. It comes on fast, lasts maybe about a minute and a half. It's like someone turned a burner on inside your body, and then it goes away. And you may have a handful of them in a day, or you may have a few hundred in a day. Night sweats, I talked about the vaginal wall thinning or atrophy, which can also lead to recurrent UTIs. So these are the cluster of symptoms that people, men and women, will experience as they have this hormonal drop as they age. And this is, to be honest with you, this is what drives people to come into our clinic is I don't feel like myself. I have all these symptoms. Please help. So what drives people to come in are these symptoms. What drives me to want to give hormones to patients who are experiencing hormone depletion are not as much the symptoms, though, of course, I want to help people feel better, but it also is really important the health benefits. And this is something that really doesn't get addressed enough. Menopause is not just about hot flashes and painful intercourse. Menopause is the onset of a whole new time in a woman's life, an andropause, which is the male version, a whole new time in a man's life where their body is not reacting or behaving in the same way that it used to, but the organs are also suffering as well. So these health benefits of hormone replacement are really important and an important part of addressing optimization of hormones. And it is actually based on the knowledge we have now. And I preface this because there's still so much more research that needs to be done, but specifically what we know so far with women is that these health benefits are best obtained if we do hormone replacement therapy within 10 years of the onset of menopause. So for most women before the age of 60. That doesn't mean you can't have hormone replacement after the age of 60. You can still do it and get the symptom benefit that you're seeking, but to see the actual health benefits, the sooner the better that you start hormone therapy, either after or before even menopause. And these health benefits are significant, you guys. There are studies that show significant decrease in cognitive impairment, 64%. The incidence of dementia and Alzheimer's is decreased by 35%. There is a 50% decrease in the risk of coronary artery disease in women. It produces improved cholesterol and overall reduces cardiovascular inflammation. Hormones also build bone. Estrogen prevents the breakdown of bone. Testosterone helps build bone. So the two together help maintain strong, healthy bones. And we have studies that show that there is up to a 50 to 60% reduction in the risk of hip fracture in patients who are on hormone replacement therapy compared to those who are not. Similarly, there are studies showing 25 to 40% reduction in the risk of colon cancer, as well as potentially a 21% decrease in the risk of diabetes. So it's not just about symptom treatment. And this is really important that you understand because I hear a lot of people say, well, my doctor told me just grin and bear it, you'll get through it. There's no getting through this time of your life, menopause or andropause. It's the beginning of this new phase of your life, and there is no end to it. So, really, if you just take the attitude of, I'm going to grin and bear it and get through this, you're going to be sacrificing your health at the same time. And suffering with those symptoms while sacrificing your health is not, to me, an ideal situation. So, with all that, let's talk about what is the truth about hormone therapy because you hear different things about that it causes cancer and women shouldn't do it, and that really all started with a study that was called the Women's Health Initiative Study and was published in 2002. So I'm going to take a minute here and dive into that. So this is a study um, that made headlines and really virtually overnight completely changed how millions of women were treated for the last 2 decades. So, this is a large NIH funded study of over 16,000 postmenopausal patients aged 50 to 79. They received conjugated equine estrogens plus a medroxyprogesterone. So, what that means is that they were receiving synthetic estrogen that was derived from horse urine, which is what Premarin is. And then they were also receiving a synthetic progesterone. So this is what we call Prempro. So all synthetic, estrogen and progesterone, and they were followed and assessed for the effects of HRT on heart disease, breast cancer, and osteoporosis. And the authors of the study basically concluded and wrote, this is a quote from the study itself, that these findings are the first confirmation from a rigorous clinical trial that taking estrogen plus progestin increases the risk of breast cancer. This was the conclusion, and this landed overnight, changed everything. There's just one problem. The study did not actually show that hormone replacement therapy increased the risk of breast cancer. That is not what the study found. So, what happened? Well, the authors of the study decided that they saw a trend that they thought could mean that it might increase the risk of breast cancer. So they stopped the study and they went to the media and they told the media that they were stopping the study because there might be an increase in the risk of breast cancer. And this made headlines overnight. But about a week later, after all the headlines came out, the actual study was published in JAMA. And when anyone with a discerning eye who understands statistics and understands research studies, clinical research studies, read through this, it was very obvious to them that what is in the headlines is not what's in the study because the actual published study did not show a statistical difference in the rate of breast cancer. In fact, it showed absolutely no difference in the rate of breast cancer in early breast cancer between women who were on HRT versus those who were not. And in terms of invasive breast cancer, which is obviously the more scary, there was only a slightly higher number in the HRT group. That number was 1 out of 1,000. For every 1,000 women, there was one more in the HRT group compared to the non-HRT group. But the statistical finding there was that that was not significant. It did not rise to the level of significance. That said, and this is highlighted here in the actual article, they actually wrote that it almost reached nominal statistical significance. What that means in lay terms is we saw a trend. This suggested there might be an effect, but the evidence wasn't strong enough to conclude there was an effect. But all these headlines came out. And in my 25 years now in medicine, I don't think I can think of another incident where it so dramatically impacted, where a study overnight dramatically impacted the way we treat an entire population of people. We instantly, patients became afraid, doctors became afraid, it became taboo. The FDA had a black box warning on estrogen, and it was stopped. Women who were on hormones were told to get off. Women who were going into menopause and had terrible symptoms were told they just needed to get through it. And that is effectively where we've been for the last 20 plus years. So the issues with the Women's Health Initiative is that it used incorrect statistical analysis. It misrepresented the findings. But the other thing it did is it only studied synthetic estrogen and progesterone. They did not look at bioidentical HRT. But once this study hit the headlines, all HRT was considered taboo. There was no research into, well, if that's synthetic, maybe we should look at bioidentical and see if that's better. It just froze everything. And it hit with such an impact that it became what we call dogma. Dogma is belief that is so deeply rooted, it is presumed to be fact. But it's still just a belief. Dogma is not fact. And we are still fighting the dogma to this day. I'm sure some of you have gone to your doctor and asked about hormones and been told you don't want to do it, or if you're going to do it, only for a few months because it can cause breast cancer. That when you hear that, you are hearing the sounds of dogma coming out of people's mouths who don't understand that they were duped 23 years ago, 24 years ago. What we know now is entirely different, and understanding that bioidentical hormone therapy is different than synthetic and can have a different way it reacts in our bodies is really important. So I want to talk about this bioidentical versus synthetic. So synthetic hormones are manufactured. They're not identical to what the molecule is in your body. As we're bioidentical, these are derived from natural plant sources, and the actual molecule is the exact same as the molecule your glands make in your body. The classic synthetic HRT, hormone replacement program, is typically a one size fits all dosing. You get a prescription for a patch or a pill. Every woman who comes in gets the same. Every man who comes in for injectables gets the same. As where with bioidentical hormones, it typically involves more personalization and, looking at lab results and that sort of thing. But importantly, there's a difference in the side effect profile between these two. There is a higher risk of side effects with synthetic HRT compared to bioidentical HRT because these are two different molecules that behave differently in the body. And so here's an example of this. This is looking at progesterone. On the left, you have progesterone that is made by your body, your natural source of progesterone. In the middle, there is prometrium. Prometrium is a bioidentical progesterone. And if you look at the molecular structure of both of them, you can see that they are exactly the same. Progestin is the synthetic hormone. And as you can see, as I highlighted in red there, it has these additional chains on it. And this changes the structure ever so slightly. And why that's important is because of that lock and key mechanism that I talked about with hormones. They bind to the receptor and they bind to the specific receptor made for that hormone. Well, the synthetic hormones are similar enough that they can still bind the receptor on the cell surface, but they're altered enough, they're larger molecules, they tend to bind longer. And the longer the hormone is bound, it can produce much stronger, prolonged downstream effects within the cell. And we can, I mean, this could be talking about a picosecond. It's just a fraction of a second time difference that these two different molecules are bound. But what can be the downstream effect can have be significantly bigger. And this is what can lead to the incidence of higher risk of side effects and that sort of thing that we have seen with some synthetic hormones. So, synthetic has the wrong molecular structure. We see higher risk of blood clots with it compared to bioidentical, which really has, I've never seen a blood clot form from bioidentical hormone replacement therapy. Bioidentical HRT comes with lower cancer risk. Actually, in the face of the Women's Health Initiative and their faulty conclusion, it actually is protective of the breast, not increasing the risk at the breast. HRT, all the time, I have patients come in with migraines and we get their hormones balanced correctly. We can see those migraines disappear, as where it can be a side effect with synthetic. Mood can really be affected. Synthetic progesterone, to me, is one of the worst medications on the planet. It can cause significant mood changes, especially in women, depression, suicidal ideation. We don't see that with bioidentical. Bioidentical will promote sleep versus disrupting it with synthetic. We get better libido, better effect on weight, and overall, just fewer side effects and a healthier profile. So I want to talk about what are the options with bioidentical. So first, let's address who's a candidate for HRT. So who are we talking about? Well, we're trying to, with HRT, we're trying to restore hormones to that occur due to aging and to try and get you back to your optimal range for health as well as quality of life. So these are the symptoms that, or I'm sorry, these are the patients that we typically will assess for candidacy for HRT. So perimenopausal women. Perimenopausal women in their 30s and 40s who've developed some hormonal fluctuation and are getting irregular cycles. Maybe they're having heavier periods or maybe they're having fewer periods. Their sleep is affected, their mood is changing, they're more irritable, they're more anxious. But they're still years before menopause. They're still having bleeding, so they're not in menopause. These are definitely candidates for HRT. It may not be estrogen that we start with because you may not need estrogen right away, but you are definitely experiencing the symptoms of lower testosterone. Postmenopausal women, for sure. Now we've had the ovaries have stopped producing estrogen like they were, or they've had a hysterectomy or a oophorectomy where the ovaries are removed, and this leads to a significant hormone decline. So these women are absolutely candidates. Men with declining testosterone. I told you after age 35, men's testosterone production decreases by 3% every year, and upwards of 40 to 50% by the time they're 45 will have symptoms of low testosterone. So we treat quite a bit of men as well for this. And basically anyone with suboptimal levels would be considered a candidate. So, how do we do bioidentical or any type of hormone therapy? So, I just kind of did a generic slide here to show the different things we have available, different tools we can use to do hormone therapy. There's getting oral pills or capsules. There's synthetic forms and bioidentical forms. That's for estradiol, progesterone, and thyroid. There's no pill form of testosterone at this time. So if someone wants testosterone, then you're looking at doing creams and gels or injections or pellets. So creams and gels are typically made from compound pharmacies. They are bioidentical. You can get all of the hormones all mixed into one cream, or you can get separate creams and deliver them separately. These are where the oral capsule is something you'll take typically once a day. Creams and gels will also be done typically once a day, but usually it's an application of the cream. Often women will do it at night or that sort of thing before going to bed. Patches, we sometimes utilize patches. Those can be both synthetic and bioidentical. I only use bioidentical pills or patches when I do any type of that type of replacement. Typically, the patches we use are for estradiol. Injections at this point is just testosterone. It's synthetic testosterone. It's a pretty common thing for men to do. It's less common for women. I do know some women who've done injectable testosterone, but usually it's much heavier in the male population. And then pellet therapy, which we'll talk about a little bit more in a bit here, which is purely bioidentical, and you can get estrogen and testosterone. The pellet is a small implant that is placed under your skin and dissolves over time. Lozenges are things that will dissolve under your tongue. At this point, all I ever use that for is progesterone. Progesterone can be an oral capsule, and you can get that bioidentical, or you can get a dissolvable lozenge as well. So really, when we look at all of this, we address the individual patient. What are their needs? What's their lifestyle? You have to factor in all of this to determine what is the best type of HRT to do for them. But these are the tools we have to choose from. So I'll talk through some of the advantages and disadvantages of each. So with oral, it's nice and easy, convenient. You take it once a day. Often it can be covered by insurance, so you can get it from a regular pharmacy. You can adjust the dosing, and it's pretty quick and easy to change dosing if you need. One of the downsides to it is what we'll talk about a little bit is a peak and valley effect, where you take the pill and you get a surge of hormone, and then as time goes on in the day, it starts to decrease. So you get more of a peak valley. Sometimes women will have more breast tenderness with this. You do also, it does get passed through the liver, so there can be breakdown to other products that can cause side effects. So we can see headaches and slight increase in the risk of blood clot, even with, based on the knowledge we have now, even with a bioidentical oral estrogen. Transdermal, these are going to be the creams and gels or the patches. So, advantage again with creams and gels, we can easily adjust dosing. We bypass the liver so we don't get those breakdown products. It can have some flexible options for people. Big disadvantage is just the messiness of it. You have to apply it and wait for it to absorb. You don't want to touch your partner or your pets because you have to make sure you're not transferring any of the hormone to them. And it really does produce creams and gels. While they can provide some benefit, they typically give us a less consistent, there's variable absorption. It's harder to get a consistent, reliable level from the hormones. Though we do use it, it's often useful if someone wants to just take a really slow approach with getting into hormone therapy. This can be a nice, gentle way to ease into it. Patches, like I said, I use these mostly for estradiol. If we're going to do a patch, nice consistent delivery that bypasses the liver. It doesn't have an increase in the risk of blood clots like we can see with some oral form, and it's usually changed once or twice a week. The big disadvantage is skin irritation. That is what we hear the most. People will have a reaction to the adhesive, or it can fall off and loosen easily. And it's just something that you have to keep replacing. Injectable, like I said, this is mostly men doing this. Pretty reliable absorption. You're given a sub-Q injection once, or know some men who do it twice a week. Gives a pretty consistent delivery. You'll get a surge of testosterone and then a slow kind of decline over the next couple of days with that. Typically can be quite cost effective and easy to adjust the dose. Big disadvantage is synthetic, so higher risk of getting side effects with that. You're having to deal with needles. And then that peak and valley again as you get the surge of testosterone and then the decline over time. And then finally, pellet therapy, which, to be honest, full disclosure, this is my preferred method, and I'm not embarrassed to admit this is what I use for myself. I think it's the best method, most ideal for optimization. That said, like I said, I take each patient as an individual, so not everybody is right for pellet therapy. But what's nice about the implant, it dissolves slowly over time, and so it provides a nice consistent hormone level. You'll get an increase after the implant is placed, and then it stays over months and then slowly declines. Women typically will get 3 to 4 months out of their pellet implant, and men will typically get 5 to 6 months out of it. So it's sort of nice. You don't have to think about it on a daily basis or a weekly basis. You come in, 3, 4 times a year for women, a couple times a year for men, and it bypasses the liver. It's easily absorbed, gives us very reliable and consistent blood levels. But it is not covered by insurance, which is a disadvantage. I do just briefly want to touch on this a little bit closer to help you understand it. So, pellet therapy, this has actually been around, believe it or not, since the 1930s. My jaw hit the floor when I first learned that about 8 years ago. It was like mind-boggling to me that they created this in the 1930s, and how was I only hearing about it in the year 2020? It was like stunning to me. We didn't learn about any of this in medical school. Barely touched on hormones, by the way, in medical school. Your average doctor gets about 15 minutes of hormone education in medical school. So that's partly why there's so much confusion as well. But pellet therapy's been around a very long time. These pellets are very tiny. They are little tiny. They're about the size of a grain of rice or even smaller. They get implanted. Typically, we place them in the upper buttock area, just under the skin in the fatty tissue there, and they slowly release their bioidentical hormone over months. They're custom compounded, so we have a lot of different variability we can do with dosing, which is really nice. So we can often tailor it to the individual and their needs and their symptoms and their blood levels and all of that. They are only bioidentical, so we're not using any type of synthetic, and produce really very few side effects and very manageable side effects. They are placed via a very simple procedure. It takes me under 2 minutes to place a pellet in someone's backside. It is just do a little bit of local, place a tiny incision, get the pellet placed, and that's it. So it's often very easy to do. And like I said, you only have to think about it a few times a year. And then the beauty of pellets, and this is really why I love pellet therapy, is that it actually mimics your natural physiologic delivery of hormone. So let me briefly explain that. In our bodies, naturally, we release hormone when needed. So if you're sitting on your couch watching TV, you don't need a surge of testosterone. But if you're out in the wilderness and you run into a bear, you're going to need a surge of hormone. So it's based on cardiac output. What that means is it's based on how much blood your heart is beating forward. The more relaxed and at peace you are, the lower your cardiac output. So, similarly with the pellets, when we place them in the subcutaneous tissue, it's not a time release. Time release means that the same milligram is released during a 12-hour period, every 12-hour period. That's not how this works. The way pellets are dissolved is it's based on blood flow and that cardiac output. So at night, when you are sleeping, you don't need a lot of hormone, very little cardiac output to the area, very little absorbed. But if you are very active during the day and doing a lot of, or you're under a lot of stress or that sort of thing, you'll have more. So it's meeting your needs as driven by your cardiac output, which is mimicking our natural physiology. And this, it provides that steady state. So this is here in blue. This is injections or pills. I mean, this is just meant to be sort of simulate that peak and valley effect. where you're at your peaks, you might go higher than you need to go, and at your valleys, you're in troughs and your symptoms return. So you can get side effects and then symptoms. If this red line or orangish line here is the minimum therapeutic threshold we need to get above, you're only spending a portion of the time above it, as where with pellet therapy, we can stay above it consistently for months. So, who's a candidate for pellet therapy? Anyone experiencing hormone imbalance, who've got suboptimal labs, who prefer just to make it easy, give the pellet, not have to think about it. Maybe they've tried other methods without getting adequate results and they just want to avoid daily having to deal with the mess of creams or deal with having to remember to take pills. I hear that a lot. People who can't remember to take pills really love having pellet. If you have an active hormone sensitive cancer, you're not going to get pellet therapy. In fact, you're probably not going to get any type of hormone therapy. Anybody with an active cancer, I don't know anyone who's going to do HRT in that situation. Though, if you've had cancer in the past and have been treated and demonstrated cure from it, then that is a possibility. If someone is wanting to have something that's easily reversible, then maybe starting with something like a cream makes sense. I think I mentioned that if you want to start slow with it. Or if there's a need to really fine tune and do rapid dose changes, then maybe starting with a cream or pill might make more sense. And we do not do pellet therapy in anyone who is pregnant or actively trying to conceive. And that includes men. If you are wanting to have children with your wife, hormone therapy can decrease your sperm count. So we will not do hormone therapy for that. Okay, so finally, now we'll get into just sort of what it takes to optimize your hormones. And these last few slides, I want to kind of go through how this works. So, step one, you need to understand lab results. So, if your physician that you're going to for hormones is not checking your labs, then there is no way they can really identify what your optimal value is. And normal lab values don't equal optimal lab values. And this is probably anyone who's going to a conventional, regular, your primary care doctor looking for hormones. This is the wall you're going to run up against, is that they get your labs, and these are male labs here. So testosterone 685, the doctor looks over and says, "Oh, you're right in that range, so you're normal." That is incorrect, actually, because that's not what this range is. This range is not a normal range. What the range reflects is that it is the average of a large population of patients. So a lab develops these reference ranges based on the men or the women who come in and get testosterone checked. And if every 53-year-old man comes in and it falls somewhere on this in this range, they build that range as a confidence interval to say 53-year-old man is likely to fall somewhere between 264 and 916. So it's telling you what's statistically common, but these values aren't associated with the presence or absence of symptoms. So if every 53-year-old man coming in has symptoms of low sex drive, fatigue, can't sleep, they've got hormone dysfunction, then all this range represents is low testosterone, not normal. So you have to interpret labs in the presence or absence of symptoms to determine whether that lab value means you have low testosterone or normal. Any physician who's not asking you that question about your symptoms is not understanding. If they're just looking at your labs and saying, "Oh, you're normal, you're in the range," they're not understanding how this works. And step two is really important to me, is individualized care. Every single person has a different biochemistry from the other. So there is no light switch here with HRT where, "Oh, you're out of hormones, so here, let's flip the switch and give you hormones." It's that everybody's different. So this is HRT, when done right, is tailored to you, but that means there's a little bit of trial and error as we try and do that. And two patients can have the same level and one feel great and one feel different. So the lab values we talked about is critical to understand that it looks different from person to person, and we have to provide individualized care, which means understanding, doing a thorough medical history on each person, getting a comprehensive comprehensive symptom review, doing a careful lab analysis in conjunction with that symptom review, developing a patient-specific plan, and then what's so important is a low and slow approach. I do not believe in cookie cutter medicine when it comes to hormones. That to me, it doesn't make sense because you're taking different bodies with different biochemistries and applying the same treatment that is fraught with peril. So a low and slow approach means starting conservative and then a gradually adjusting. This means it may not happen overnight. You may not feel optimized right away. It may take us a few months to get it right. But the goal is to eventually get it right and minimize your risk of side effects. And then finally, so important is close follow up. We do in person or phone call follow ups at least every few months to make sure everyone is are they getting their symptoms relieved? Are they having any side effects? We also get labs following the first treatment and anytime we change the dose. We want to know where your symptoms are at a certain lab value. And if we change your dose, how did your symptoms respond and what's the lab value associated with that? So that ongoing symptom assessment and tracking is critical, as well as monitoring for side effects and adverse reactions. And then just an important thing I wanted to add in there too is making sure I've had so many women come to me and they've had HRT from somewhere else. They've been getting estrogen for the last 5 years, but they haven't had a mammogram. And that's really important. Now, you may go, why, if it doesn't cause breast cancer? The reason it's important is that no matter what, whether you're on HRT or not, you may develop breast cancer. That may happen to you. And if it does, and if unfortunately you develop a kind that is sensitive to hormone like estrogen, then if someone is just giving you estrogen and not surveilling your breast health, they are potentially putting you at risk of having, if you have an estrogen sensitive tumor, that could lead to increase in the growth of that. So it's really critical that follow-up in women involve annual screening mammograms if you're on estrogen to make sure that we maintain breast health. Okay, so I've said a lot, I've talked a lot, and thank you all for staying with me. The key takeaways to wrap it up: hormones are important, have widespread effects on your tissues. They decline in both men and women and start as early as our mid 30s. There's no evidence that HRT, especially bioidentical HRT, causes any risk of breast cancer. These are structurally identical to what your body naturally makes and have fewer side effects. But the care HRT must be individualized, not a cookie cutter one size fits all approach. And it's not only safe, but it is vitally important for your health as well as your quality of life. Okay, so with that, I'm going to open it up to questions, and Chris can jump on and read some of your questions. I also have put up our contact info if you want to learn more, or if you have questions after this and you want to get those addressed, please feel free to reach out to us. We have a phenomenal patient care coordinator in Marissa, and she can answer a lot of questions. Or if you're interested in learning more and coming to meet us, she can help facilitate that as well. All right.
All right, first question we have, is there a maximum age limit?
Great question. And right now, I don't have an answer for you on that based on the literature we have right now. There are physicians out there telling people that there is. You shouldn't do it after age 60 or after age 65. That's not based on studies. There are no studies that have said that. We need to do a lot more research. Unfortunately, research has been very stalled in this area. So I don't have a clear answer to provide you that says definitively that there is or isn't. In terms of symptom relief, women above the age of 60 and 65 do still come to us, and we are able to provide symptom relief. But the question that remains is there an alteration in the safety? And unfortunately, I don't have a clear answer for you on that. But that, again, is why we monitor very closely those patients as well as other patients, just to make sure that we are staying safe and that we're not, monitoring that their heart and lungs and all of that are good and healthy as they continue to do this.
Great. And second question, will I need to be on hormones forever?
That might be the number one question I am asked besides, does it cause breast cancer? So, and the answer for that is a little bit involved. When your hormone levels decline, they are never going to go back up. Your body, your glands have stopped making the hormones or stopped making them in sufficient amounts. You've developed symptoms and you're seeing your body change. So if you start hormones, you might feel better and you might get the health benefits. And then if you decided to stop hormones, then your body is going to go back to not making hormones. So, do you have to be on it forever? No. It's not like if you start it now, your body's just going to never make hormones again and you're dependent on hormone therapy. That's not the case. When you get hormone therapy, your ovaries or testes will naturally produce less because the blood levels are higher. So it recognizes, oh, we have plenty of hormone, we don't need to make as much. But once you stop taking the hormone therapy, then your blood levels will drop and your glands will start making more. But they will never make what they used to make in your 20s and 30s. So my answer to that is often, as long as you are feeling good, you will want to stay on hormones. But if at some point you want to dabble with going off hormones and see how it feels, you're not putting yourself in any kind of risk. You're just going to lose some of the benefits that you were getting.
All right. If there are any other questions, that box at the bottom that says Q&A would be the place to type it in. We hit about our hour mark here.
Great. And I do want to emphasize, like I said at the beginning, there will be more of these. There's so much we didn't even talk about, like about getting more into the lab values and what are the ranges that we try, that we typically will see symptom relief and all of that, and the ins and outs of hormone therapy and how that will impact you if you decide to do it. We'll do more of that with future webinars. So we'll keep you guys, it will keep you abreast as we develop more.
And this is being recorded. I will email out to everybody that registered for the webinar so you can review this later. If there was some place that you missed, you had to pop out for, or if there's someone you wanted to share the webinar with that wasn't able to attend, you'll have a link to that. And then, as Dr. Hosser has on the screen there, a way to get in touch with us for any other questions. Thank you, everybody.
All
Appreciate it.
right.
Thank you,
Thank you.
Dr.
Have a good
Hostetter.
night.